Thank you, everyone. I really would like to thank President O'Yalerin, the trustees of Kalamazoo College, the people from the Arcus Foundation leadership who are here today, as well as the leadership of the Arcus Center for Social Justice Leadership, particularly Carol Anderson, and Andrew Tyner, who's been my human GPS today, taking me all over campus. I'd also like to thank the students that I was able to meet today and work with in class, the faculty, and some of the members of the community I met. It's wonderful to be in a place where there is an ethos of social justice. One thing I think I've learned, if I am any kind of leader in social justice, what I've learned is that we lead arm in arm. We don't lead one person in front of another. And I hope that as this movement for social justice grows between community and academia, between black and white, between rich and poor, that it will be something that we take forward arm in arm, moving together, and that this series of leadership will also include people from the very communities that are most affected by injustice. So that brings me to Haiti. Haiti's a place I have learned to love. I've been the medical director of Partners in Health for 11 years now. It's kind of amazing, isn't it, Anne? I've seen many changes, wonderful changes in our organization. I've learned many things throughout the world. I've learned many things at the numerous universities I've had the pleasure of visiting as well as attending. Yet nothing has taught me about life like Haiti and the nation of the Haitian people. And so before I talk overly much about what Partners in Health is doing in Haiti, I'd just like to share a few things with you. First, about Haiti's Cataclysm. One event shaped the future of that island. One event in a series of aftershocks that continue till today. 1 in 10 people were affected by this event died immediately, and many more will die in the future. There has been a long-term impact on the life expectancy of the Haitian people. And the large-scale movement of people has resulted in permanent demographic shifts with long-term economic consequences. This one event I'm talking about is slavery. This was the cataclysm that was the foundation for the Haitian nation. And in fact, in the very early hours after the earthquake, as I was taking care of the sick, I was next to my very good friend, Dr. Fernet Leond, who's a Haitian physician. And I looked at him with tears in my eyes, and I said, "This is an apocalypse." And he said, "Joia, slavery was an apocalypse too, and we beat that." And it's important for everyone to remember as we face this cataclysm in Haiti, this cataclysm of the earthquake, that Haitian people are unique, uniquely strong, uniquely determined to fight adversity and to fight for human dignity. And in fact, the very first universal movement of North and South solidarity in the modern era was the convention to ban the transatlantic slave trade. And in fact, Haiti itself and the Haitian rebellion and later revolution was critical in ending the slave trade. So were things like the media. This is one of the very first public relations campaigns that ended the transatlantic slave trade, which was the Brooks ship, the diagram of the Brooks ship. This so shocked the world, who was led to believe that the Africans were being brought to a better place on some kind of Caribbean cruise. This was the symbol that was used by the Quakers, who tried in solidarity with their African brothers and sisters to end the transatlantic slave trade. Why does this matter today? It matters deeply to the Haitian people that we not forget this. Haiti is the only country that beat 3 colonial powers in the same year: Britain, France, and Spain. Napoleon's France. The loss of Haiti to the French economy was so significant that France had to sell that little purchase called Louisiana to the United States, which started westward expansion. The first president to embargo Haiti was not George W. Bush, nor was it his father. It was Thomas Jefferson, because he was so afraid of a nation of free black people. And Haitian people believe, and I agree with them, that the impoverishment of Haiti is not a poor country, it is an impoverished country, and the impoverishment of Haiti started way back then, way back to the first cataclysm that began when Columbus landed on that island. These are 2 of the heroes of Haiti. This man here is Toussaint Louverture, born a slave in French Saint-Domingue, who led the uprising against first the French, then the Spanish, then the English, then the French again, to free his people. The first president of Haiti, Jean-Jacques Dessalines, imagine a president who every day, when he is disrobing before bed, is covered with scars of the whip. This is from where the Haitian people have come. So when I landed in Haiti, having understood that a real practice of medicine is, in fact, a liberal arts practice, that one must understand history, one must understand race, one must understand sociology, political economy, anthropology, colonialism. When I first landed in Haiti, we drove by, I was picked up by a good friend, one of the drivers that I've known for 10 years now, who's an uncle to my son. We passed by the devastated palace, the devastated Ministry of Health. The Ministry of Justice was just a pile of rocks, and the stench of dead bodies under the rubble was nearly intolerable. And I said to my friend, Tifrere, I said, Kote neg mawan, where is the free man? And he said, Lila, he's here. We drove by the palace, and here, in fact, stood the statue of Neg Mawan, the other hero of the Haitian Revolution, who is immortalized in this statue, which is of a person nearly naked who has just broken the chains of slavery, because in Creole, Neg Mawan means at the same time the marooned man, the free man, and the runaway man. And that is the paradox of Haiti, that people were taken from Africa, and at the time of the Haitian Revolution, 70% of Haitian slaves had been born free men and women in Africa, 70%. And so Neg Mawan is a free man who's run away. And instead of hiding in fear, he's blowing a conch to call his brothers and sisters to revolution, to fight for nothing else but human dignity and self-determination. And as I was standing by this statue, I started to cry. I got out of the car. And this summed up so much for me about Haiti's future and Haiti's past. And an old lady tapped me on the shoulder. She was wearing a headscarf. She's a Haitian woman who had been displaced, who was living on Champs, the general palace. This is an old picture of Neg Mawan in front of the ruins of the capital. And I said, Neg Mawan toujours campé. He's still standing. She looked at me. She started to weep. And we hugged each other. And she said, Chérie, Neg Mawan pas jamais écrasé. The free man will never be defeated. And so it was with this spirit that I moved forward with my team of 4,000 Haitians that work for Partners in Health in Haiti. Not a single American there full-time. 4,000 Haitians who were already in community, already had gone to the areas affected. And we sat together and tried to say, okay, what do we do for this apocalypse? How do we continue to fight for human dignity and struggle together arm in arm to make this better? So this is the map some of you have seen. This is the devastation of that very palace, the palace behind the statue of Neng Maon. And in fact, this small earthquake, 7.0, as compared to Chile's earthquake of 8.8 on the Richter scale, decimated Port-au-Prince. Decimated Haiti, Léogâne, Carrefour, Jérémy, Jacmel. Why? Because Haiti is impoverished. Because Haiti never has had the resources she deserved to build an adequate society based on freedom and justice. And as a result, those buildings came tumbling down. So many people died, 1 in 10, about the same proportion that died in the Middle Passage. 250,000 people dead, more than 3,000 injured, and 1.7 million people displaced. This will transform for all of the future, the history of Haiti. No one will forget this day, that 50 seconds when history was made. So Partners in Health has a very clear idea of how we work to assure human rights. We look at human rights as a definitively two-pronged approach. The first is what I consider the relatively mainstream, yet not easy, part of a human rights approach. And that is working with community, empowering community, trying to engage community. But we don't just do it by education, we do it through jobs. We do it through arm in arm walking together as colleagues, as friends. So today our staff around the world is 11,000, 80% of whom are poor people. All but 70 are local nationals. So we have a very grassroots approach, and we feel that empowering, engaging, working side by side in community is one of the principles of the human rights approach. The other principle is something that we have learned over time, and that is only governments can really respond to a human rights demand. And since we started to receive AIDS money from 2002, Partners in Health, when I started at Partners in Health 11 years ago, we had one charity hospital. We had 75 patients in Peru. When we started to get AIDS money, we said, you know what, AIDS is a matter of human rights. Health is a matter of human rights. And the way to enable human rights for that community is to make sure that those rights are delivered through the public sector. Because people can't demand a right from a church, from a charity. They demand a right from their government. But we know that in the history of Haiti and in the history of development in general for poor countries, the strategy of privatization has progressively disempowered governments, has progressively shrunk the public sector in education, in health, in infrastructure. And so our strategy has been to enable and support and assist governments in delivering on their rights to the people. So the two-part strategy of engaging community and supporting the public sector. So as I sat with my colleagues who had come to Port-au-Prince, my friends, of course, we operate in Haiti 10 public facilities. So we couldn't poach our entire staff. But many of the leaders, both community leaders, medical leaders, came down to Port-au-Prince to find their families, to bury their dead, and said, we're Haitian, what can we do here? So we sat together and said, is it possible to have a human rights strategy like ours in a disaster? Because we're not disaster people, and I can tell you quite honestly, I hate disasters. Some people like them. I was surprised to see. There's kind of an adrenaline thing. We saw people getting off the plane after day 2 with earthquake 2010 written on their jackets. You know, I'm not that guy, right? And Partners in Health, I would argue, is kind of not that organization. Yet, we have a large Haitian staff. Everyone has been affected. We want to contribute, and we want to do it in a way that is consonant with the human rights approach. So I'm going to share with you some of the ways we did that. One of the things, as I mentioned, we learned from HIV is that we could use HIV as a battle horse, that the battle wasn't against HIV, but the attention to HIV gave us the money to get into a much bigger battle, the battle for healthcare as a basic right, and that would be delivered through the public sector, as I said. So this is one of the very first clinics we took on, Clinic Saint-Michel-Boucan-Carré. And here you see that the clinic is sort of, well, closed. All right? This clinic, which now, by the way, is a beautiful hospital, and I don't have a picture of that because I want to show you something a little different than a beautiful facility. This is 3 months later at the same clinic. Now, I'm an academic, so you could criticize and say we didn't control for the rainbow-colored awning, and that is true. It may have been that all these people came for the rainbow-colored awning, but I don't think so. We did 4 things with HIV money. 1, we got rid of fees for service, because if healthcare is a basic right, we shouldn't be commodifying healthcare. I know you people who are against healthcare reform are going to call me a socialist like Obama. 2nd, we paid the staff. Because in fact, the public sector staff, again, because of the impoverishment of the Haitian government, hadn't been paid in 9 months. In fact, one of my good friends, who's a physician, I went to the market one day and he was selling radios. And I said, "What are you doing selling radios?" He said, "You know, I got to pay for my kids to go to school." He was a physician in a community that, by the way, has a life expectancy of 42, and he's selling radios. Something's wrong with this picture. So we paid the staff. 3, we actually put in essential medicines, because as Haitians often say, we may be poor, but we're not stupid. And people are not going to walk 10 hours to a clinic to get nothing. So with these interventions, and then number 4, engaged, trained, hired, paid community members to go out and do what we on the medical side call active case finding. On the social side, I would call social shepherding. Going into community and seeing who are the vulnerable, where are they, what do they need, how can we help them? Many times the community health workers were themselves people who were vulnerable. And with those 4 things that, by the way, none of these had anything to do with HIV, right? I didn't say HIV meds. I didn't say HIV doctors. I didn't say HIV community health workers. We filled these clinics. And in a matter of months, we've replicated this today in 52 facilities around the world. That these clinics are broken because of the impoverishment of the public sector. And if you have a community strategy, but the community comes here and there's nothing for them, that's not a rights-based approach. So we said, okay, what's the public facility in Port-au-Prince that's going to be attending to the needs of the poor? And we went to a totally broken down, horrific place called l'Hôpital Général, where there were 1,500 people on the lawn. No pain medicines, no running water, no electricity. And in fact, I saw the first thing that made me cry after seeing all the things I had seen. Really made me sob. I cried at Negmau, but sobbing, seeing Mrs. Thompson, the chief of the nursing staff at l'Hôpital Général, with a cell phone in the middle of the night trying to draw blood from a child. And I thought, my job is to help her deliver this basic right. She's a public servant. She's living out of a car, I later found out, where 8 people are rotating and taking shifts, sleeping because her house has been destroyed. She has 1 shirt, and she is with dignity trying to draw blood from a small child. So we said, okay, we're going to help. This place is a mess. We're going to help get electricity going. So we actually had a good friend he's actually a construction magnate, but he first was trained as an electrician, and we said, we could use that. came down and helped the electricians at the General Hospital to get the place up and running. We went into the building, scavenged whatever we could find to put together a set of anesthesia machines. And we got volunteer teams of American surgeons because, by the way, at the time of the earthquake, there were not enough orthopedic surgeons in Haiti to even deal with the normal load of medical care, no less this. So we need it. But we said, if you volunteer with Partners in Health at the General Hospital, you are volunteering to work with, side by side, arm in arm with the Haitian staff. And that doesn't seem like a big deal. But I can tell you one of the things that happens in disaster is this kind of weird, almost alien invasion of hermetically sealed pods of the Red Cross and the Swiss government, and everyone has their own tent, and the Haitian staff's wandering around saying, where do we work? Well, you can't work here because if we have Haitians in our tent, then we can't guarantee the safety of our Swiss people, whatever that means. So we said, you will work together, you will establish operating rooms that can be run by the Haitian staff whenever they choose to return, because, by the way, many people were still having funerals, finding their families, figuring out how to manage their day-to-day life. So this team, and some of these people were actually from Kalamazoo, Grand Rapids area, this team is Haitian, American. Of course, the guy who's sitting like this, that's a white guy, of course, American. Craig McLean from Boston Children's Hospital. The hard-working people on here, mostly Haitian. It means rounding with the Haitian staff. It means working with Haitian residents. It means working with the medical students there. And we are saying, okay, we cannot take on the challenge of this entire hospital by ourselves, but what we can do is accompany this hospital back to life, which means working on grants together with them, putting together a foundation with them, bringing in staff to fill the gaps, and it is a terribly hard job. We could have gone to a private hospital. In fact, we had one surgical team that came, and I won't mention what big city on the East Coast they were from that I'm also from. But they said, we cannot work here. This is substandard. So they went to a private facility, where they did some good. I mean, no problem with that. But it wasn't a public facility. And we have set up this partnership, which is not easy. This is another scene from the tents, because, of course, the buildings themselves were destroyed, so most people are getting care under tents. This strategy of the public sector strategy was what we already were working on in central Haiti and in the Artibonite. So we had multiple sites. This is just 4 sites. One is our old charity private hospital, which is a beautiful facility where we already had 2 operating rooms running. 3 public facilities where we already had operating rooms, x-rays, anesthesia machines. So all we needed were the people. So Partners in Health, within a very short period of time, we were able to help open and staff 20 operating rooms in the country. And we did more than 3,000 surgeries with our Haitian partners and colleagues. So this strategy of using, at this time it was back then AIDS money, maybe now it will be earthquake relief money as a battle horse to improve surgical care in Haiti, because we believe that it was never adequate to begin with. And what we want to say is this money should have a long-term effect on Haiti. Should have a long-term effect of improving the surgical care. This is actually, the church of the hospital in Conch. It was started by an Episcopal priest, which was converted into a very large post-operative ward, where the choir would go around and sing at night. It's kind of beautiful. Kids, grown-ups, lots of disabled people in Haiti's future need a way to go forward with that. So then the second part of the approach, so we figured out a way to help the public sector in this terrible disaster, and in fact we found that the public sector strategy we had already enacted was able to be flexible and nimble and respond to this crisis. What about community? Well, we've always felt that our biggest and most important interaction is at community level. This is my friend Dr. Fernay Leon, who I mentioned earlier, doing a home visit himself. He's a big shot. He's been with us 17 years. He's sitting on a porch with a family, with a community health worker, with a mom, with a kid. And that, in fact, not only should the patient be the center of the interaction, but the community itself. So, what's the community in a disaster? Well, we actually didn't know. I didn't know anyway, but I'll tell you, my Haitian friends and their colleagues, they knew. Why? Because they were from those communities, right? Because even if they were working in central Haiti or in the Artibonite state, many of them had families and homes in the capital. It was always the case that nearly half of the population lived in Port-au-Prince. So within literally hours of the earthquake, we had doctors, nurses, etc., health workers, social workers out in communities where people were spontaneously organizing, because this is the model Partners in Health, being on foot. Shoe leather social justice. Well, or horse hoof social justice. This is my friend I was telling you about that was from Haiti and was not very happy that the one African country he got to go to had snow. So this is Siberia, of course, where we have community health workers that work on foot, Mexico, Guatemala, Haiti. Everywhere, Boston included, we are walking, we're there with the community, for the community, arm in arm. Not one person in front of another person. This is actually our very first meeting in Rwanda in 2005 when we started working there. And the first thing we did was not meet with officials, was not go to the hospital, was have a community meeting. And then, in fact, again, just Dr. Fernay Leon, my other colleague Michael Rich, many members of the community, most of whom now are community health workers, do work with us in Rwanda. So we said, okay, let's go outside of the clinic and figure out what the community looks like. And in fact, within hours, it was obvious that communities had already spontaneously generated and were organized, as is the case often in Haiti, where it's a very organized sort of community solidarity model. And we hired community workers and organizers from those tent cities, because we thought it'll give people jobs, it'll decrease the likelihood of violence, frustration, desperation, and it will help us deliver services. So whether it was people to fill in forms, whether it was people to carry stretchers, whether it was people to feed the sick, to help the elderly or children, we were able to hire hundreds of community members to participate in the approach of delivering health care in these camps of internally displaced people. So as we worked with the government identified 4 major camps of people who were displaced, and they said, Partners in Health, we would like to do this, but we don't have the means, we don't have the people. You do it. As you see, I think there's one random white lady there who's a photographer, but these are all Haitian staff. And how do we do this? Because we couldn't take our staff from our 11 facilities that are bombarded with patients. But the fact that we have an all Haitian staff, they knew lots of friends whose private practices had been destroyed on January 12th and were looking for work. And we were able to, in a day, hire 50 physicians and 100 nurses, all of whom were Haitian. So we didn't have to bring in boatloads of volunteers. We didn't have to bring in lots of people. We brought and gave jobs to local people to kind of also help jumpstart the economy in this terrible disaster. And today we see more than 1,000 patients a day in these community clinics. So the last 2 things, just thinking of how we have taken this approach to a disaster and tried to make human rights hay out of it. One was the community approach, one was the public sector approach, and then there's a couple other things that we're hoping we can move forward in Haiti to places they never were before. One is surgical care, as I mentioned. The other is mental health and rehabilitation. Haiti is a place that always has had a desperate need for these services, and we're hoping now we'll have some funds to create a system, not just for people who were victims of the earthquake, but long-term. This is a young woman who lost, as you can see, her leg, and was fitted with a prosthesis. But we're also doing similar things for people with psychological wounds, with mental wounds from this terrible tragedy. And so those are things we're going to look at as ways to look at the earthquake relief as a battle horse for improving those services. And then the last thing, which is a little bit self-indulgent, but I want to share with you because it's something I'm particularly proud of, is that we really have decided that we're going to focus on medical education. That Haiti has no future if we continue to lose professionals. That the flight of professionals from Haiti in the last 30 years has been horrific, and now with institutions crumbling around them. So 3 years ago, we created a fellowship in global health delivery, which was a two-way street. See, I'm a professor in global health. I don't want global health to only be about how I educate my Harvard students to take care of poor people, poor black people in the third world. I want it to be about changing the pedagogy of what global health is, who does it, where it's done. And so we created a fellowship for people working in the field to deliver care in an equitable fashion, to deliver care with mindfulness to social justice, being able to work with community members. And on February 27th, which was only 6 weeks after the earthquake, we had canceled it, but we decided anyway to hold the first graduation of our first 20 fellows in global health delivery, which is a Harvard fellowship. They are now accredited as part of the Harvard Academy. Many of these people now are experts in our projects. Many of them were grandfathered in, so people like Maxie Raymondville have been with us for 20 years. His fellowship was only 3. We've told him he could leave now. And my dear friend Mario Paginel, who was awarded his fellowship posthumously because he died in the earthquake while attending a meeting for Partners in Health to look at ways to have community-based approaches to non-transmissible diseases. But these men, no women yet, these men are experts in the world. They've been consultants in Gabon and Burundi and in Malawi and Lesotho and in Ethiopia and all throughout the world because they have learned the social justice, human rights, and community-based approach. And they are the professors, in fact, for our residents and students in global health. So we're hoping that as we move forward, medical education will be at the forefront of the work we do as well in Haiti. So we've got lots of challenges to remain, and I promised that I would leave a little bit of time for questions and keep to my 40 minutes. We have a huge problem with displacement that hasn't been addressed. We still have thousands of people living in absolutely inadequate shelter. These are not tarps, with the exception of the blue ones. These are sheets and towels. The rainy season is upon us. People are hungry. This needs to be addressed. It's a humanitarian crisis today. It's only going to get worse. Many of these displaced people will flee up north from Port-au-Prince to the sites that we are already working in. We expect a massive and permanent change in the demographic of Haiti that we're hoping to be prepared for. So there are many things in the future, but we do hope that the human rights model of community engagement and public sector strengthening can happen even in disasters, and that as Haiti deals with putting back the pieces and hopefully reconstructing a society that is much, much more durable than before, the society that Haitian people have always deserved, that the human rights approach will be front and center to this. So I want to acknowledge Negmaon, the spirit of resistance, the fight for human dignity among the Haitian people, and my amazing colleagues at Zami La Santé. Many of them had lost everything. And I just want to highlight one person, Gabriel, a community health worker from Léogâne. He lost his wife, he lost his 5 children. And he came to us and said, "What can I do to help my people?" So we hired him as a community organizer, and he alone shepherded probably 400 patients to surgery at one of our facilities. So it's to people like Gabriel and my other friends at Zami La Santé and the spirit of the Haitian people to help each other. I want to thank you very much for inviting me to do this lecture, to inaugurate the Arcus Center for Social Justice Leadership. I encourage all of us to lead arm in arm in recognizing history, in recognizing the richness of community and the human rights approach. Thank you very much.
Thank you, Dr. Mukherjee. On behalf of Kalamazoo College and on behalf of the Arcus Center for Social Justice Leadership, I would like to really, again, thank you for your thoughtful and your provocative and your passionate words, and not only that, but for your work and your example. Thank you. My name is John Duga. I teach in the Political Science Department here at Kalamazoo College. I'm here to facilitate the question and answer period. And we do have time. We've got perhaps 25 minutes or so. The way that we're going to do this, we have 2 microphones set up, one there next to Dr. Les Tung, he's raising his hand, one there next to Dr. Jan Tabachnik. And so we would like to welcome you to come forward with your questions. Dr. Mukherjee has generously agreed to engage in this give and take with us. And just, it may seem a little strange, but the process, the procedure is going to be the following. Please ask your question, and then I will repeat the question. The reason I'm going to repeat it is that this is being filmed, and if you ask the question on one of the 2 microphones, we're not going to be able to pick it up on the film. So if you can please ask your question, then I will repeat it, and then have Dr. Mukherjee respond. So again, I would encourage you to if you have a question, please come on down. So the question is a question for advice from someone who's just been accepted to work with an NGO. She's a licensed clinical art therapist, will be working down in Haiti for the next 10 years, traveling down, going for 2-week periods twice a year.
Listen and watch. See what wonderful talents people have, and build capacity. You know, if you're there for 2 weeks, you should be there as a listener and to try to support the artists that are there, the work that people are already doing, and facilitate, whether it's bringing materials. You know, often people have so many talents, what they're lacking is not even the skill set, it's the resources. So I would say try to listen and learn and do what you can to build local capacity there.
The direct question is, what kind of work has Partners in Health done in Burma?
Partners in Health is not working in Burma. I'm sure there are lots of great humanitarian organizations there. I think Burma is one of those places that's quite complicated. If you look at this human rights approach, because the public sector is not responsive to the needs of the population. So I'm sure it's quite challenging, and I admire you for wanting to go back to your country, and you hope that you are able to do so.
So the question is about the programs that Partners in Health runs here in the United States, in Boston, and what kind of different challenges do they face in the United States as compared to their work abroad?
You know, it's interesting that the challenges are not that dissimilar. Because I think we still have a lot of difficulty bridging social class between the medical establishment and affected communities, communities that are marginalized, that are poor, and then add to that race, which is always present in the United States. It is also to some extent in Haiti, although a little bit less. And so, you know, I think what our community health workers do, and again, I would emphasize that what we want them to be is community health workers, you know, really members of the community that can represent the needs and the obstacles and solutions from the community in shepherding and helping affected people get access to medical care. And so that's what our community organizers and community workers do in Boston. What's interesting is it's been hard to get people to engage harder in the States to raise money for something like that than in poor countries. We do pay community health workers as well in the U.S. As we do abroad. And so people are more moved by the pocketbook, and we've had to show that we can save money. Now, I believe that it's better approach, regardless of if it's more or less costly, because investment in the community has many, many positive synergies that we're not measuring. But we have been able to show that we saved money in terms of reducing hospitalizations, et cetera. And now it appears that Medicaid, so Massachusetts Medicaid, is going to pay for this program to be extended for people living with asthma and diabetes, because they believe that will keep people out of the hospital. I'm always reluctant to use that economic argument myself, because if we left everything up to economics, vulnerable people would remain vulnerable. But it has been a suasive argument with trying to expand our work in the U.S.
The question was, how do we implement the Partners in Health model here in the United States, given the increasing culture of privatization and the commodification of health services?
It's a great question, and I wish I have a better answer for that than to say we need a larger social movement. I mean, I think if we look at the organization on the right of the debate in terms of calling Obama a socialist and, taking down, there was very little ethos for fighting for a public option. And so I don't think really things can change without a real movement. And so part of the work starts right here in colleges, and and even President Obama himself said that he was hoping that this was one step in the right direction. We cannot look at this as finished, because as a finished product, it is not a right. It is not equitable, and we still have 25 million people who will likely be uninsured based on this, including a much larger proportion now of undocumented people, which we've never had trouble covering in a state like Massachusetts. So I think we have to look at this as there's some political will, but we have failed in terms of a social movement. And I think it's high time that we sort of really look at ourselves introspectively in the more progressive factions of the United States and say, what are we doing wrong that we could not counteract, the really kind of weak and poorly thought out sort of Tea Party whatnot. I think we're failing to act in a socially coordinated fashion. So it's not a great answer, but we're trying, but our community approach is up against a system that is not a public system, that it's not a rights-based system. So there are huge challenges.
So the question is concerning Dr. Mukherjee's response to the dominant response of global NGOs to disasters such as the Haitian earthquake. What are they doing? What are they spending the money on, et cetera?
So, I will answer that question. It doesn't make me happy to answer that question, because it's been a very, very sad thing to witness on two fronts. One is the public sector impoverishment will continue unless we act. So American assistance, which was some of the fastest assistance to get to Haiti, less than 1 penny on every dollar went to the Haitian government. 46% went to the American military. So I think we have to look at disasters with solidarity and compassion, not with law and order. I don't understand that approach. It doesn't make sense to me, and it didn't seem to work in terms of getting money to the people, getting help to the people. The second part is it's not really community-based strategy, because most of that money went to US-based organizations that have almost no Haitian staff and that have very large overheads in the United States. So I think we have to really rethink what our human rights framework is and fight for that. And this is why I think the thing that's going to help Haiti, I mean, Haiti will help Haiti, Haitians will help Haiti, but if there's a thing that we could do to help Haiti, it's really to have a movement for Haiti, an international movement of solidarity, not unlike the movement, the North-South solidarity movement that helped to end apartheid in South Africa, not unlike the North-South movement that helped to advocate for AIDS treatment in Africa. I think we need to, people tell me, ask me, are you worried the media spotlight's going off Haiti? The media spotlight's gone. It's not going, it's gone. And so, but a movement lasts longer than the media spotlight and can use the media spotlight. And I think the things I would highlight is Haiti needs money to get to the grassroots, and Haiti needs a public sector that can actually, respond to the demands of the population. And so we have to rethink how aid is given. It's occurred to us over many years, this is not just from the earthquake, that a lot of the way U.S. aid is given anyway comes from the 1961 Foreign Assistance Act, something we were talking about at dinner, which is really a Cold War relic. And it really says, we don't want to support big government, we want to privatize, put money in hands of American companies, make sure we buy American. I mean, this is not the way to give aid that's going to be lasting and durable in countries, in my view. So this sort of way, high-profile organizations raise more money, and they're not accountable to the Haitian people. If we believe in democracy, there's always this schism that puzzles me between sort of civil society and government. But if we believe in democracy, so often civil society is kind of code for anything that's not government. They'll say, government is corrupt, so give the money to civil society, right? But civil society, in a democracy, the biggest civil society act is voting. Right? So if you really want to enable the voice of the Haitian people, you'll allow their government to stand on their 2 feet. And then if people don't like that government, they can vote the bums out. But groups like ours have no accountability to the Haitian people. Groups like the American Red Cross have no accountability to the Haitian people. So we would like to ensconce ourselves in a process that we think has accountability. And so what I saw was a lot of NGOs sitting in the capital city, in the UN compound, behind barbed wire, very afraid, only going out with security detail, in the setting of pain and suffering. And yet I was all over the city with my Haitian friends, taking care of the sick, casting fractures, bringing water at 3, 4 in the morning. We never had violence, we had nothing. So there's this part, and you cannot also have a discussion about Haiti without having a discussion about race. So the more NGOs you have means the more white people who are there. I mean, this is just a fact, and I think we have to demand a certain amount of local presence, feet on the ground, people who speak the language, people who can be accountable to their fellow citizens, which is an approach that is both community and public sector. That is not what I saw 90% of the time in the disaster, and nor is it really what you see most of the time in just sort of standard operating, but it gets worse during a disaster because people justify it even further, and the sort of siege mentality is justified even further, and it just doesn't serve any purpose, I think, other than to further otherize people who are suffering.
So we have 2 very quick questions. First, who are your heroes in life? Second, where do you see yourself in 10 years?
Yeah. My heroes really are our community health workers, our accompagnateurs. Some of them are individuals like Jean-Claude in Rwanda, like Margaret in Haiti, like Serge in Tomsk, Siberia. They're my heroes because they're not the ones who are on the front page of the paper. They're not the ones that get books written about them. They're not the ones that get to have a really excellent vegetarian dinner over here. They're my heroes because they're often every day getting up, wondering how they're going to feed their children that day, and still doing the incredibly heroic work of that walking to visit patients. And to me, what is a hero? I don't know. To me, a hero is someone who makes you feel humble in their sight, So those are my heroes, really. They are our community health workers. And some of the doctors that I work with are really heroes, too. Maxie Raymondville, who's been with us for 20 years. His family lives in Fort Lauderdale. He's boarded in OBGYN in the United States. He chooses to work in Haiti because he's Haitian, and he wants to help Haiti be a better place, So those are the people who really sort of humble me when I sleep in my comfortable bed in Brookline, Massachusetts, and, you know, get out my fancy schmancy guitar and, you know, sing some songs about revolution. You know, those are the people I think. Where do I see myself in 10 years? This is kind of an optimistic one, but let me just throw this out to you. We've got to get the world to care. And when I think about that picture, of that boat, you know, there was a transformative change in the mindset of human beings around the time of the abolition of the transatlantic slave trade. And the world got better, right? And Martin Luther King says, you know, the moral arc of the universe is long, but it bends towards justice. I believe we can hang on that thing, you know, and make it bend quicker. And I don't know, 10 years, but I want, you know, it's a doable thing to eradicate child malnutrition. It's doable. We have enough food. Kids don't have to die of starvation. It's sick to me, you know, to be in a clinic an hour and a half from Miami and see 3 kids in a week die of starvation. We could stop that. You know, we could stop that through pictures, through media, through solidarity, you know. We could stop it in 1 country. We could stop it in 10 countries. We could stop that. You know, we don't have people have leprosy much anymore, hardly at all. We could say, you know, in our lifetime, there are 24,000 kids that die every day of preventable diseases. 60% of them have underlying malnutrition. That could change in 10 years just by making people care. So where I see myself in 10 years, maybe 15, is saying to my kid as he goes off to perhaps K, you promised him a spot, right? You know, when you were little, we had to tell people that children don't need to die of hunger. And he'll say, get out of here. You know, that there's some massive shift in sensibility around what's acceptable for children, regardless of the color of their skin. I think that's a doable thing. Will we get rid of all poverty? No. We can eradicate severe suffering like that in less than a generation. I think we can do that. And so that's where I want to be, is kind of retired from social justice work and as a singer, as I'm sending my kid off to K, and saying, you know, I used to take care of sick, you know, hungry kids, and now I can sing for my supper.
A two-part question, which is that as a leader of an NGO, how do you evoke a sense of personal responsibility when you go into a country? And secondly, how do you ensure that there is a lack of corruption in the organization as you leave the country?
When you were saying evoke a sense of personal responsibility, I thought you meant mine. Yeah, I don't worry that much about that, and I'll tell you why. You know, I think if there's one thing we should, I used to say this before the Wall Street crash, but I think we can say it now. You know, Ann McCormick knows this. When Wall Street kind of fell on its face, I kind of danced a little jig, right? Why? Not because I want people to suffer, not why because I want, you know, my mom to lose her pension or anything, but because corruption, you know, where there's money, there's corruption. You know, we have sort of fetishized this idea that the public sector is corrupt, right? Or poor governments are corrupt. But, you know, is a poor government corrupt, or is AIG corrupt? Is Enron corrupt, or is, you know, Zimbabwe corrupt? I mean, there's a potential for corruption when you have money without systems, right? Money without systems. So at Partners in Health, our goal is not to just pass a bunch of money, nor a bunch of medicines off, right? We are about systems. And this is something, I've learned from the AIDS movement, is you create money, but create a system of accountability and transparency. So just like I wouldn't go in as a doctor with a wheelbarrow full of AIDS medicines, dump it in central Haiti and say, here you go. I don't do that with money either. I say, let's sit together, figure out what our milestones are, how are we going to measure them, how much money is this going to take? And in the Global Fund to Fight AIDS, TB, and Malaria, which is a large part of money for AIDS treatment, if you don't meet those milestones, you don't get the next tranche of money. That's the kind of system we are talking about. That's the kind of system that they're going to try to do to improve all this, terrible corruption on Wall Street. That's the kind of system they, put together. When I was in medical school, the gal who was supposed to do our yearbook, who was one of our students, she disappeared with the money. I swear to God, this is not a joke. Why? Because, we were students, we didn't have a lot of money, and she just kind of little by little spent it. So you could say, medical students are corrupt, right? Or you could say that without systems of accountability and transparency, you have no business in giving out money, medicines, whatever it is. And so one of the things we've said in the wake of this crisis is we believe the government needs money, but we know for a fact that they don't have systems of accountability. We know that because even if they had, they were destroyed. But we know that they didn't because they were such an impoverished government to begin with, no one ever trusted them with any money. So we have said, look, we, Partners in Health, we will be sort of an honest broker for the government on the health side. We'll help them. We'll help them put together systems, et cetera. We never got money for the Global Fund to fight AIDS, TB, and malaria without getting doctors and accountants and bookkeepers, right? The first time we had our first money from the Global Fund, I was working on the budget, which is a scary thought, with our accountant, who is Haitian, and he was adding up a $2.6 million budget on an adding machine that spit out paper tape. Okay, that's the level. We don't have that anymore. We have accountants that use highly, sophisticated software, but that took capacity building. So I think when we look at these things, rather than just use corruption as a blunt instrument against poor governments, we should say, where there's corruption, there's money, or where there's money, there's corruption, and it's our job as solidarity, right? Arm in arm to say, let's put together systems that will combat this. That's how we approach the problem, from a systems approach rather than a personal responsibility approach.
The question is about brain drain and how the American medical system or the training of doctors contributes to brain drain.
Yeah. Huge issue to me personally. I think other than my comment about my musical future, that's probably where I am going to spend a lot of the next 10 years of my life is focusing on education in these settings. I think there's lots of aspects to the brain drain that we have not addressed well. I mean, obviously, payment is one huge thing. People, particularly in the public sector, they're not paid. We have to change the system that it's not this impoverished, chronically bankrupt system. That's going to take massive advocacy. We're on it. We need partners on that front. We're compelled to do that. The second thing is training, even for our Haitian doctors or Haitian nurses, is often a very Western-focused training, and people learn to do stuff that they're never going to be able to have the tools and the resources to do. So I think you got to do two things. One, you have to bring the resources and tools, because when I've been doing surveys, I've been doing some work with this with our staff, and we have excellent staff retention. And we pay okay, but not great. We pay middle of the pack. In fact, when I say, is it money, they all laugh at me. But they say having the tools that they need to do their job, one, having responsibility, being able to have a little bit of a budget, a little bit of freedom for innovation, because, doctors, nurses in these countries are often the most educated people in the country, right? How many poor countries have had a doctor as a president or a prime minister? A lot, right? So, they want a little bit of responsibility, a little bit of flexibility, innovation. And one of the geniuses about how our project in Haiti is run, and I credit my friend Fernay Leon with this, is that each of the sites gets a little budget, essentially for innovation. And the team, which is community health workers, doctors, and nurses, gets to decide what they've done. And we've learned some very cool things from that, because it's driven from the community, and the doctor gets to have a say, the nurse gets to have a say, the community gets to have a say. So, there are these aspects of work environment that are really, really important and shouldn't be neglected. Pay is important. Innovation, a little bit of control. Communication is really important. You can't expect people to be in the middle of nowhere with no way to communicate with their families. Putting in internet for us has been a key thing. Transportation to the city. Many people are willing to commute, right? but not if they can't get transport. So, you know, for a lot of our doctors and nurses and social workers, you know, professional people who are living in rural areas, we do provide transportation for them on the weekends so they can visit their families who are usually in capital cities, right? So that's the sort of internal brain drain of people trying to get people to stay in rural areas. What about the brain drain to the United States and Europe? Well, I mean, I would be the last person to say that we should limit people's migration, because I think that's, you know, that would be really a negative, you know, an anti-human rights approach. And I think if people want to study abroad, you know, they should be able to do that. We have made a very strong point that we do not pay for people's higher education in the States. But what we're trying to do with this fellowship that I was telling you about and other programs like that is to say, we're not going to pay for you to come, but we will bring a Harvard education to you. Right? So really not only bringing the tools to do your work, but the tools to advance yourselves that can be done in your own country. Because in fact, this is where the action is. This is where our students and residents want to come. Why not you, you know? And sort of have a way, and I think like a lot of these folks who are now fellows in global health delivery, hopefully will be able to become academics in their own institutions, you know? So I think there are many ways around it. We need to train more doctors and nurses in the United States. I mean, one of the things that feeds the brain drain is the huge number of vacancies for doctors and nurses in the United States, in primary health care, in poor communities, in rural areas, et cetera. So, you know, some of these places, like Western, I hear, is opening a medical school, Oakland. You know, we need to train more doctors and nurses. I personally don't think it's that hard of a job, frankly. You know, and they shouldn't make it so damn hard to become a doctor in this country, you know, so.
So the question comes from a Kalamazoo College junior who is weighing the decision between going into medical school or pursuing global and public health. And the direct question is, how did Dr. Mukherjee come to this approach of partners in health?
So, you know, I really believe that you can attach social change and social justice to anything you do. I was just mentioning our accountants, you know. A guy in our organization who was at J.P. Morgan for 17 years and decided he wanted to be a social justice finance person, right? Seriously, and we need that. So I don't really think, you know, I think the ethos of looking at how the world has to change, which is coming from you guys, you know, you students, like much more than it did 25 years ago, right? And so I think any of us can look at what we do, whether it's civil engineering, accounting, art therapy, music, you know, physical education. There's so many things that can and are needed in terms of transforming the world. The most important thing, though, is to sort of realize what we learned from community. And those experiences I had personally before medical school. You know, I worked with communities, you know, women who were victims of domestic violence. I worked in some poor communities in Lansing, Michigan, and in Detroit. I learned really a lot about sort of dignity and really what was needed as the difference between solidarity and charity. The difference between I want to save people and I want to sort of help people save and better themselves. You know, there are big differences there, and most people who are poor and who haven't had all dignity beaten out of them, which sometimes happens too, you know, they want to be part of the solution. So by the time I got to medical school, I wasn't looking at myself as, you know, a purveyor of health, right? I was looking at myself as someone who had a certain skill set, right, that I would then bring to the community that had a different skill set and really try to work together to sort of improve health. And those were lessons I learned from working with poor people in the United States that have been, you know, retaught to me over and over again. So I don't really think it matters. Like, I think for all of you students, you should do what you're passionate about. Do what you're passionate about, what you're good at, and what you can be creative about, right? Because creativity is very important to social justice, I think, you know. What you can be creative, what you can think out of the box, what you're willing to be flexible, what you feel strongly about, enough that you can be flexible. Like, I was a chemistry major. I hated chemistry. I was bad at chemistry. Like, no good idea about chemistry would ever come out of my head because I wasn't confident enough to think creatively, right? In medicine, it's different. I like medicine, right? So I can think out of the box. I can listen to people, integrate their ideas, and sort of look at social change. So I would say, find what you're passionate about. For some of you, it may just be community work in general. Then you're lucky, right? Because then you can just do anything and be a social change agent. But I think for many of us, it's, finding that professional niche and then saying, what can be transformative about this? Look at some of these people in information technology who've done that. There are so many fields. So I would say, don't worry overly much about medicine versus this versus that. It really should, for social change, I don't think it should be about healing a person. It should be about, working with a person, working with people. And I mean, my friends who are primary care doctors in the US would say the same. You can't be a doctor and heal someone who doesn't want to be healed. You can't heal someone who's living in an environment that's not healing. So looking at what the whole social context is, what the context of that person's life with that person, with that community, I think that's the goal. So I think, being a doctor is a great job. I'd highly recommend it. Don't study chemistry if you don't like it. Nothing against the chemistry majors. But I think really thinking in a creative space about how to be transformative with your life, that's the way, I think, toward social justice.
So I know that there are more questions, but I also have been given the signal that it's time to wrap things up. So to provide some final remarks, I would like to invite Calissa Jarrett up. You heard wonderful things about Calissa earlier on, senior HDSR major. Calissa.
Again, I would like to thank you, Dr. Mukherjee, for coming and imparting your knowledge and passion on us. Your engagement with Haiti, both before and after the earthquake, shows a true dedication to social justice, even across borders. Listening to you here tonight reaffirms my desire to continue my work with the Arcus Center for Social Justice Leadership and stay involved in social justice issues in my life after K. How can any of us remain unmoved by stories such as Mrs. Thompson, the director of nursing who helped people using the light of her cell phone, or Gabrielle, the man who lost everything but still continued to work in his community? Their stories and the images on the screen really put a human face on the extreme poverty, devastation, and loss of life out in Haiti. They demonstrate to each of us that there is much we can do to help the people of Haiti and other developing countries. I'd also like to thank Mr. Stryker and our Arcus Foundation guests for your generosity and foresight. When I answered an email asking me to join the planning committee of the Arcus Center for Social Justice Leadership, I assumed I was one of many students to be asked. I mean, after all, so many of us are committed to social justice here at K College. I had no idea it would just be me and Ben representing the entire student body. But it's been a great experience serving with the other committee members, giving voice to my ideas and those of other students, watching the campus actively engage in social justice issues. To be honest, I didn't know what I was getting into when I joined the committee. As a civic engagement scholar, leading a service learning project in the city of Kalamazoo, I felt like I knew a lot about social justice. After serving on the committee, I appreciate even more the dedication to social justice on our campus. Future students are really in for an amazing experience. Kalamazoo College has a way of encouraging students to take leaps of faith, whether through internships, externships, study abroad, service learning, SIPs, or even joining planning committees. But when we look back on these leaps, we realized they were all just steps in the K plan designed to make us better learners and better citizens. Now students can add the Arcus Center for Social Justice Leadership to that list of steps, and they will climb even higher because of it. Ben and I have one last duty tonight. Dr. Mukherjee, in order to keep you and others and partners in health well dressed on your travels, we've put together a collection of colorful, and some might say gaudy, items from the Kalamazoo College bookstore for you. So. Thank you, everyone, and have a good night.